Hi, welcome to the last installment of our Global Neuroscience Institute conference. It's been an incredible 3 days, and we appreciate everyone logging in, checking in, and all the incredible questions that you've had. And now we're going to round off with kids. And kids are not just little adults, and I'm very fortunate to be here with one of my partners, Dr. Tina Loven, who will convince us that kids need surgery too, and maybe sometimes not. And we'll go over some of the things that we've been up to at St. Christopher's Hospital. Tina?
Hi, it's a great pleasure to be here. And my name is Tina Loven, and I am a pediatric neurosurgeon. My favorite part of pediatric neurosurgery are my patients, because they are so freaking good, cute, and you'll see soon. I'll have a couple of cases I wanted to just show you on what comes in the door, and that's the other reason why I like pediatric neurosurgery. Is you see a lot of things, and they really range from a child who bumps their head to congenital problems and some unfortunate acquired things like tumors and epilepsy. So this is one of my patients, and as you can see, it's an adorable little gal who came to our neurosurgery clinic, and the parents had noticed that the forehead looked a little odd. So the baby was born breached and was assisted with forceps on delivery, and you know, the baby's skulls are pretty thin, so as soon as I saw this baby, I was suspecting that there was a fracture. And the baby skulls fracture in a very unusual way. They are so soft that it's what we call a ping-pong fracture. The bone is like young wood. It just kind of bends but doesn't really break. So what we did is we sent this little one for a scan just to confirm and just kind of get an idea what we were dealing with, and this is what we saw. And you know, we took the baby to surgery, and it was a very simple procedure. We basically just made a small nick in the skin, and we were able to, with a very, very small opening to the bone, to just kind of put an instrument in and elevate the bone back up. Sometimes these fractures can be elevated with just a vacuum, but this fracture had been sitting there for a little over a month, so it wasn't as easy as it could be if they just happen and you can intervene right away.
What would you have said to the parents? They would have said, well, surgery is awfully scary. I want to see what happens.
So that's always an option, but yeah. You're gonna have a pretty upset teenager, yeah. Especially a girl, when they have a big dent in their forehead, and you know, we always have to reassure the parents, because it is very scary, yeah, when you're talking about a little baby going to surgery, sure, going to sleep. This, yeah, will be their first anesthesia experience. It's always, you know, very, very scary. Just letting go of your baby for that amount of time, we make sure that we really, really take great care on taking care of the parents just as much as we take care of the babies. We call them from the operating room. Okay, we're making an incision, we're getting started. Yeah. Okay, we're closing, everything went well, and you know, we're really, you know, that's really part of the whole experience of pediatric neurosurgeries. Is the parents are just as important and just as much patients as your patient. Yes. Yeah.
Well, what does he look like, or she?
So she looks, you know, again, adorable, just as adorable as with the dent, but I think this will be a happier teenager, and he's going to need a lot less makeup. So.
And how are the parents?
So parents very, very happy.
Good.
And they they left the next day, and all went well.
Awesome.
That's why we'll.
Well, what took so long to have that child presented to you? I mean, it does not take a neurosurgeon to realize something is off here.
Yeah, that was very interesting. So I think the hope was that maybe it'll just pop back on its own. I'm not quite so sure on what happened there, but the pediatrician, certainly, these were first-time parents, so.
Sure.
They don't know how the babies are supposed to look, and all babies kind of look funny when they come out. They have all kinds of...
You say that to all the parents?
Like you say, all babies look like aliens.
That's my kids that look like that.
Yeah. No, they I guess...
But if you go back to that or the CAT scan, a couple things. One, so CAT scans are radiation, and it's obviously the best way of looking at bone, but at what point in time, there are two questions here. When do you use a CAT scan versus an MRI in a little kiddo? Does this kiddo have to be put to sleep for that? And also, you call that a ping-pong fracture. I think somebody in our audience was wondering why such a benign name to something that needs surgery. So,
CAT scans we use when we want to get a very good look at the bone.
Yeah.
And we certainly want to avoid radiation on children, young people, pretty much on everybody. And we have instituted a number of protocols to do MRIs whenever we can. But unfortunately, MRI does not give the best look at the bone. So in this case, was it really necessary to get a CAT scan? You could argue it because you see really what you're dealing with, but you also want to make sure that there's really nothing bad underlying, that there's not a big hemorrhage and or something that you would have to worry about. So that will give you answer to both. It'll give you an answer to what the bone looks like, and we have a protocol for the kiddos to give them the least amount of radiation with the CAT scans. So it doesn't give you the best detail, but it gives you just enough that you know what you're doing and you can do it safely. And to the second part of the question, why such a benign name? Anyone who's played ping pong, when your ping pong ball gets dented, it looks just like this. I didn't invent it. I think it's a cute name, and it also helps when you're talking about the fracture. Okay, there's a ping pong fracture. It's going to be an easy thing to elevate, just like a ping pong. You just squeeze it a little bit, and it'll pop right back up.
Okay.
So.
What else do you have for us to look at?
So this is another cutie.
They're all cuties to you.
They're all cuties.
Okay.
That's why my job is so great. And my staff can attest to that, because we just run around in clinic and say, "Oh my goodness, did you see that baby? How adorable! Oh, did you see the outfit?" So yeah, we're a little silly in pediatric neurosurgery. This baby came in with a funny shaped head. We see a lot of funny shaped heads. Sometimes they're completely benign. They just get better with repositioning the baby. Sometimes when the babies are in one position in utero, one side of the head gets flat. If the babies prefer to sleep on one side, that side gets flat. Mm-hmm. So you see a lot of funny shaped heads. But we are also very tuned to what's just a funny shape and what's pathological. So baby heads are all made out of pieces of bone that's connected by lines called sutures. So the sutures have a certain order of turning into bone, into fusing, in order to make up the skull into a certain shape. If the sutures fuse too early, they can create problems. And one of the most common sutures to fuse, like in this case, is the sagittal suture. So you can see that there's all these lines that are open, but right in the middle that suture on a 3-month-old is closed, and that's not normal. So what would happen with this baby is the baby's head would be very, very long and narrow, sort of a boat-shaped head. So this was picked up early by a very good pediatrician and sent to us, and we were able to treat this baby early. So we have some of the...
Is there an advantage to treating early versus late, or what do you feel?
So I think so. I think the earlier that we catch these single suture synostosis early fusions, the easier they are to treat, and the better the cosmetic results is. The bone is very, very thin, and if we catch them early, we can treat them with minimally invasive techniques.
Got it. Is that what you're showing here?
So this is actually a baby that was treated with an endoscopic suturectomy.
Wow.
Where we make just a very small incision. There's very minimal blood loss.
Sure.
Babies usually don't need any blood transfusions. They, instead of spending 2-3 days in the hospital, they go home the next day. Mm-hmm. The cosmetic result is excellent. We do use molding helmets afterwards, but they usually do very, very well. So I think there's a certain advantage of being able to treat this early. And
what would you say to a parent if they came to you because their pediatrician sent them and they were apprehensive about the operation or the synostosis? Will this one in particular, would this affect their cognitive abilities or their ability to develop and do well ultimately, or?
So it can be argued that certain degrees of synostosis can be elected not to treat, especially very, very mild metopic synostosis where the forehead ridge fuses, but there's really no significant cosmetic deformity. But on the other hand, it can be argued that it can cause problems because if there's not enough space, if one of the sutures fuses early, it can create problems with increased intracranial pressures, and that can lead to cognitive problems and other problems.
You know, I think that changed also over time as you started having more endoscopic approaches. I know in my training we were sort of a little bit blasé about whether we should fix these or not. But you're right, Tina, if the brain vault is supposed to expand and grow in a certain way, presumably it's better for the brain if it can.
Yeah.
So you're just allowing physiology to occur.
And it's such a small surgery if it's done early, that you know, I think it has more advantages than disadvantages. Yeah. Of course, every surgery is risky, and if it's your child, you know, it should not be taken lightly because bad things can happen.
So what's this one look like?
This one is, again, adorable. Adorable round head.
Adorable round head.
Yeah. So sometimes we don't catch these early because they can be very subtle.
Yeah. They
can also get you know, worse when months go on. So if it's not picked up within the first 6 months, then what do you do?
Yeah, that's an excellent point.
There's still options, and those options should still be considered because of what we talked about.
Sure.
That you can have problems with cognitive development, with increased pressures. The surgery still, we'll make it very safe. We do it together with our plastic surgery colleagues to make sure that the cosmetics results are as good as they can be. But then it's going to look a little bit more extensive. For example, this is the same suture that was treated with open surgery.
Yeah.
And you can see, you know, eventually all of that is going to be covered by hair. You can see the incision can be done in multiple ways. A lot of the times we do a bicoronal, which is kind of an ear-to-ear behind the hairline incision, or like in this case, it's kind of a
lazy S.
lazy S that also is nicely covered under hair, and you don't really, once it heals, you don't really see any traces of it unless you go looking for it.
I think it's a good point to highlight for parents or even folks that are going to refer people to you that this is a cosmetic surgery on the top, but it's a brain surgery on the bottom. And you're making sure that at least the cosmetics are dealt with by those kind of curious incisions, right?
Yeah.
I mean, that's, and also you alluded to it, that plastic surgery is pretty important.
Yeah. And if there's any more extensive work to be done, if it's a multi-suture synostosis, the plastic surgeons are excellent in using models of perfect head shapes to allow them to shape the reconstruction to be as good as cosmetically possible.
Now these are kind of big surgeries, and you can imagine that there's some blood loss, but I have to imagine that, you know, kids can't tolerate a whole lot of blood loss. So what are the maneuvers, aside from being incredibly meticulous in the operating room, that you pay attention to?
Yeah, so that's a really good question. You know, obviously we take great care on, you know, really making sure that the hemostasis is from the beginning to end optimized. But there's also medications that can be given that sort of reduce the blood loss. There's also a way to kind of recirculate the blood. But most of the time we just prepare the families that there will be a blood transfusion, and we don't certainly want to fall behind. So we kind of start that early. If we see we have a big surgery with a lot of bony cuts, we'll start the blood transfusion early. And it's usually very well.
It almost plays back into your point of doing these surgeries earlier and younger.
Yeah.
Probably means that they're less what we would call morbid or bigger, and probably less likely need for any kind of transfusion.
Yeah,
right?
sure.
Yeah.
Sure, and as you can see, this kind of surgery, they're not going to go home the next day. so they usually swell, you know, the eyes are closed for a day or two,
Yeah,
and
sure.
and they're not as happy campers as the endoscopic kiddos. Again, you know, the end result is the same. It's just the process is a little bit different.
Sure.
And some, you know, even single suture synostosis, some, you know, if you need to evaluate it, can you do it safely endoscopically, or would it be best served to do it with a little bit of a bigger incision? So it's always, safety is always the most important.
For practitioners to know, is there a time cutoff that you generally say, okay, we're moving from endoscopic to open, or is it really pediatric child based?
Yeah, so after 6 months, the endoscopic is really not as optimal.
So it's almost a reason for making sure that people do see you soon enough to at least have that window of opportunity for endoscopic versus then committing themselves only to open.
Yeah, I mean, the 3 months is really the perfect time to do.
As scary as it might be to the parents.
As scary as might be, but the bone is so thin and so easy to mold at that point that that's the best time, in my opinion, to do these surgeries. As obviously all the other medical issues are taken into consideration.
Now I know you have some lumps and bumps, as you like to call them. Why don't you show us
so
what you've been digging out?
Again, most of my day goes by at looking at head shapes and say, hey, what do you think of this lump? What do you think of this bump? You know, oftentimes we get asked, like, what is this, you know, big thing on the back? And
sometimes it's the normal anatomy.
And it ends up being normal anatomy that in a growing skull, especially if it's a first child, it's always sent over to us, and we are so happy to see all these cuties. But you know, sometimes you see something like this and say, hey, yeah, there's a problem here. There's something wrong. So this was a 5-year-old who comes in, and they've been kind of watching this big midline lump that seems to just be getting bigger and bigger. And the pediatrician's been looking at it, mom's been looking at it, and then finally they say, okay, it's not going away. It's not a birth injury. A lot of the times during birthing process, there's little bleeds that end up being calcified hematomas, and they can present as lumps. But this was a little bit of a different kind of a lump. So again, we did a few scans just because of where it was. We were kind of worried because it was right smack in the middle, and there are some big vessels that run underneath there. So we wanted to do not just a CAT scan, but we also got an MRI, and wanted to see how much of a defect we were dealing with on the skull. And thankfully, there was really no brain involvement in this, so it did penetrate the skull fully, but it looked like it was separate from the dura and from the big vessel that runs, big vein that runs right smack in the middle there.
Now, just to be kind of clearer for people, this is probably something you don't necessarily need plastic surgery help with, do you, or did you?
No.
Yeah.
These are just
these are a little bit more straightforward, aren't they?
Yeah, these are pretty straightforward, and this will hide the incision again. Just like we did with the synostosis cases, we always consider cosmesis in kids.
But if anyone was asking, would this be an endoscopic case necessarily, or probably maybe not so much?
Depends. If this was in the forehead, sure, you wouldn't want to put an incision right on the forehead. Yeah. But this was clearly behind the hairline, so we were easily able to sneak in there. And I think just because of where this is, I wanted to see where I was getting to, and just to make it safe. So this is.
Whoa.
This is what we found.
That's something not to see after lunch.
It looked like a mushroom.
Yes.
And then it came out very easily, and then we played with it a little bit before we sent it to pathology and opened it. So it looked like a big, large pimple inside.
It does look like.
So this
is that how you're going to officially sign out the path?
Yes, this is called a skull pimple. No, this is actually a large dermoid, which is one of the more common skull bumps that we see in children.
And I have to imagine that once you take it out, that's it, right?
Pretty much, yeah. That's it.
Fantastic.
So that's kind of a happy diagnosis, saying, okay, we're done now. And on a 5-year-old, we just took a little bit of the bony edges out to make sure that the bone starts growing back, and there's usually no implant or anything needed for that. Okay.
So I guess what's your next case? Because we can't talk about pediatric neurosurgery without seeing at least one shunt. And if we see one shunt, then where's the next shunt? So there's got to be a shunt somewhere here.
Yeah. So shunts are probably the most common. The most common. They are.
Yeah, and maybe just to clarify for folks, what are shunts doing? So
shunts are basically we become plumbers of the brain. There's all these fluid spaces that normally exist in everybody's brain. And there's a very delicate balance between how much fluid gets made versus how much fluid gets absorbed and circulated all around. And when that balance gets disturbed for one reason or another, just like your pipes, bathroom pipes get clogged up, the brain pipes get clogged up.
Sure.
And that is the most common problem that we see in children, and oftentimes we see problems with very, very, very tiny humans who are born too early. The tiny humans their vessels that line the fluid spaces are not developed fully, and they tend to bleed. And when they bleed, the blood gets into the pristine spinal fluid spaces, and things happen, but the end result is that the absorption part does not work anymore. The spinal fluid keeps getting made, but it's not going anywhere.
Yeah, it's like you said, the plumbing just gets clogged up, and then there's a problem.
So, then what do we do about it? So basically there's two different problems that can happen. The fluid doesn't get absorbed, or there's a block somewhere that causes an obstruction, and the pathways are not what they should be. Most of the time, we treat the obstructions as well as the absorption problems in very little babies by inserting shunts.
Sure.
In older children or teenagers, if we have a problem with an obstructed pathway, we have other treatments that work very well, and those are called endoscopic pathways that we make. We'll make new pathways for the obstructed portions for the fluid to circulate through, but in the very itty-bitty babies, those pathways don't work as well as the shunts do. So, there's very, very simple shunts that you put a shunt in, and it works great, and you never have to do anything except see the child.
And just to clarify, shunting means just taking fluid from one space and putting it somewhere else.
Correct.
Not necessarily into the brain, right?
Correct. So the most common pathway that the new pathway that we make for the extra fluid is we transport the fluid from the brain fluid spaces into another sterile fluid space in the belly. So we'll have a little silicone tubing that goes under the skin that's connected from the ventricles, and we usually want to make sure that there's a pressure valve so not too much fluid runs through it. So anytime the pressures grow too high, the valves open up and allow the fluid to circulate.
So you really are
and
a plumber.
run. I really am a plumber, yeah. That's
and
right.
What happens when you say it? Because actually amongst ourselves we always talk about this. Well, how long will that shunt last? Or what do you say to a parent when you're talking to them for the first time and they're already apprehensive and you're bestowing an operation on their child, and then unlike that dermoid case where you said, wow, we're done, and this was awesome and this is great.
Yeah.
How do you have that discussion with the shunt families? Because it's a really challenging one, isn't it?
Yeah, that's true. Usually I start by saying we'll be friends for life. So
until you transfer them to the adult service.
So it's a unfortunately most of the time it's a lifelong relationship, and it can be a very happy relationship.
Surgical.
No. The dream of a pediatric neurosurgeon is to have a shunt that you place for a child that you'll just observe and see every every couple of years, and say, hey, everything's working great. Mm-hmm. Nothing needs to be done. We like to try to leave enough tubing that even with the growth of the child, there's enough there that they don't outgrow their shunts. But unfortunately, that's oftentimes a pipe dream, and we do need to do revisions and another revision.
But that's not necessarily an awful thing.
It is not.
It's
no.
kind of an expected or potentially expected outcome.
Sure, and I had mentioned earlier that the endoscopic treatment then becomes potentially an option.
Yeah.
If you have a baby, then outgrows the shunt or shunt stops working, that's always something that we look at. Can we make this? Can we get this child shunt free?
So you must have some pictures of shunts that you can dazzle us with.
Yes, I have a very. This is a very classic.
Yeah, that is.
Kind of a picture. This is a X29 weaker, had a bleed in the ventricles from prematurity, and was observed, developed big ventricles, received a shunt. Shunt's working. This is a follow-up picture.
So just so people understand, that picture on the left, the white spaces are the fluid spaces that are really out of proportion, aren't they?
Correct, yeah. Yeah, and you can see the brain even in that picture looks really white because it's not really mature.
Yeah.
Yeah, so that's part of the lack of myelination and also being unhappy, like Dr. Sarkar here said. That's not a happy brain.
No, but the next picture really looks about as near normal as you might expect, don't you think?
Near normal.
Yeah, you have to be pretty happy with that.
The fluid spaces are still pretty big.
Of course, sure,
but they are much more normal looking, and this is just a year later. So this child's fluid spaces should still get smaller as they grow.
Yeah.
But that little red colored thing there, that's that catheter that I've outlined, just to kind of show where the catheters travel through. So this is the end result, and again, if the shunt works, we don't touch it.
Absolutely.
But if the shunt starts giving us trouble, then we'll have to think of other options.
And sometimes it's just being educating also everybody about, once kids have shunts, every cough, sniffle, sneeze, or fart does not mean that there's a shunt disorder, correct?
Right,
but it doesn't mean you can't not rule it out.
Yeah, so we do
a lot of
scare
testing.
our ER for doctors and pediatricians as well as our parents to just be on a watch out. If there's a shunt, we always have to consider that might be the cause of the increased farting.
Yeah.
Most of the time it's not, but we always are on a lookout for problems. That's why we like to see the shunt children or children with shunts in a regular basis, so we know how they look when they are healthy.
Yeah.
We also like to occasionally get some pictures so we know how the ventricles look when they are healthy, especially when they grow, and we don't kind of know. We want to get what their healthy baseline is. Because if we never got a picture after the initial picture there on the left, we wouldn't know when they have a problem.
And it looks like that other picture is an MRI scan.
Yeah. So they both actually MRI scans.
Yep.
The MRI scan on the left just looks kind of funny because the baby is so premature.
No, but just the point that you made about
yeah.
saving kids from radiation and things like that.
Yes. Yes.
What about some parents or some providers might understand that shunts are programmable? What does that have to do with MRI compatibility and things? Do they have to worry about it? What's happening with that technology?
So that technology has really developed quite a bit because that was always the problem with the programmable shunt valves, that if you put a magnet close to it, it would change the setting. Sometimes even devices like iPads could potentially change the settings of the shunt valves. The programmable shunt valves are sort of neat because you can change the settings and avoid some of the problems that we see with shunted children, like slit ventricle syndrome. You can adjust the pressures once their skull bones fuse and dial them up or down as needed. So that could potentially avoid surgery. Of course, the other caveat is that the valves are a little bit more complex, certainly more expensive, and
but it also means that each adjustment is not a surgery.
Exactly.
You can probably remember as a resident, every time you wanted to change something, if you had a fixed valve, so to speak, that was an operation.
Yeah. So
there's a lot of benefit.
There's a lot of benefit because if you discover that your shunt valve is draining too much, and you have a fixed valve in, you can't change
Yeah.
that without
Tough luck.
opening up the incision. And anytime you open up the incision, the risk of a malfunction or an infection goes up tremendously. So that's certainly a case. So, sometimes we see just kind of a simple, I don't want to say simple, but straightforward
But
hydrocephalus.
You've got to have something more wacky.
So sometimes we see fluid spaces that are wacky, like you said, and we have to figure out, okay, what's the best way to treat it? And this is an example of a wacky fluid space. So here we see lots of fluid in the ventricles, lateral ventricles that we saw in the prior picture, but also there's a funny looking space there in the back of the head.
Yeah, I see that.
And that we were contemplating what to do with it. A lot of the times, if that space communicates with all the other spaces, it can be treated with just one catheter.
Sure.
But in this particular instance, we didn't think so, and we had some sequences that we had done with the MRI scanner to sort of prove to us that that was an isolated fluid space.
Yeah.
So we inserted a catheter in there as well and connected them both to a pressure valve, hoping that now all compartments are under the same pressure.
Just so people understand, one catheter is in a very, say, standard position in what's called the lateral ventricle.
Yeah.
Where's the other catheter?
So the other catheter is in this large fluid space in the posterior part of the brain where the cerebellum is.
Mm-hmm.
And it's actually sort of on top of the cerebellum, as you see from the progressive scans.
It doesn't even look like there's a lot of cerebellum there, does it?
No, initially. So what we were thinking is this a child with a hypoplastic cerebellum?
Yeah, sure.
Is that what's called a Dandy Walker? Versus is this maybe an arachnoid cyst?
Mm-hmm.
But there's another entity called Blake's pouch, which we believe that this particular problem was where some of the foramina that allow outflow from the fluid space are not formed, and I think looking at the scan all the way on the right, that's probably the most likely diagnosis because the cerebellum looks pretty much normal.
Yeah, that scan on the right looks about as darn near normal of a brain that you could hope for.
Right.
Yeah.
So if this was a hypoplastic cerebellum, that would not
happen.
It wouldn't have grown.
No, that's an awesome result.
I have a question.
Yeah.
How should we evaluate a child with a shunt in the emergency department?
So the most important thing, like with any problem that comes to the emergency room, is history and physical. Finding out, what the problem is, when did the problem start, what are the symptoms, any associated symptoms, any kind of risk factors, any recent surgery, any recent revision surgery, and then kind of a weighing in, is this likely a shunt problem or not? If it's likely a shunt problem, or even if you are not sure, that's a call to the neurosurgeon.
Yeah.
Based on the phone call, we usually decide, is it wise to get imaging? And we always try to get the least invasive, least harmful imaging. So, if it's a little itty bitty baby, ultrasound or an MRI scan. If it's an outside facility that maybe does not have an MRI scan available, and if it's in kind of a very serious looking situation, we would at that point possibly recommend a CAT scan.
Yeah.
There's other things that can go with it. If we find that there's an abnormal looking result of the MRI or the ultrasound, we would also maybe get x-rays to look at the tubing.
Sure.
Is there any disconnects in the tubing? I probably, if everything looks normal and the follow-up scan looks normal, I would forego the imaging of the tubing, because then you would say, hey, this is less likely to be a shunt problem. And of course, before you jump into anything, if it's a flu season or a any kind of other pediatric illness season, you want to rule those things out first if a child presents with fevers and not feeling well.
But some other things like classic neurologic things like nausea, vomiting, sleepiness, irritability, headaches, I think those are all within the purview of I have to worry about a shunt problem.
Yeah, for sure.
I also want to know, what is your preference for sedation when you obtain imaging on young patients?
So the neat thing about the MRIs that we do at our hospital is that they are so short, that they are just as short as a CAT scan. So it's a 3-minute scan. The parent can go help hold the child still, and usually we don't need any kind of sedation.
So you were talking about shunts, which means that there's hardware in place, but you also alluded to when the kids get a little bit older, there are some neat tricks that you can do that are also minimally invasive that can help kids with hydrocephalus problems.
Yeah, so there's not new, but there's these alternative treatments that we've tried to get shunts out of kids, because once you have a shunt, you'll always have a shunt, and anytime something happens, that becomes, could it be the shunt problem? And shunts, they are hardware, they can break, they can get infected, they can drain too much or too little. So if we have a child that has a shunt failure, we always evaluate them to see, are they a candidate for an endoscopic third ventriculostomy. So here we would make a pathway to allow the fluid to bypass the normal route and find another way to drain. This is a very useful procedure for obstructive hydrocephalus, where there's a blockage from the fluid getting from the lateral and the third ventricles to the fourth ventricle. But it's also seems to work in non-communicating hydrocephalus fairly well. So this is a great option if
absolutely.
The only problem is that it doesn't always work.
Yeah, that's right. Well, and then you have the shunt.
Yeah,
then you can always fall back.
Yeah. And if you have a child that's under 1 year of age, unfortunately, 70% of the time it doesn't work. So is it worth it, because it's putting a child through another surgery again?
Another question is, what role does speech and cognitive therapy play in hydrocephalus patients? At what age, or do you wait to see if the shunt works?
So we always want to catch any kind of cognitive problems or speech problems early. So we always refer children to early interventions, PT, OT. Most of the preemies are really kind of wrapped into these programs as soon as they leave NICU to make sure that we optimize and give them all the opportunities to do very well. And some of our children are just amazing. You would never know that they were preemies when they come in, and it's the most rewarding part of pediatric neurosurgery, seeing these kids. And we just love them.
But it's clear that you're enamored with your population.
I want to hear,
and it's wonderful.
But enough about me. Let's talk about
you.
About you.
Yeah, I think you've just been captivating everybody with your practice. Now, I know we call this, I think we call it seizures and shunts and everything in between. And so there are some things in between, but maybe what we'll do is we'll go to some of those other things. And so fundamentally, this slide just says my name, but that doesn't really matter much. But I'm Atom Sarkar. And what I really love about being at St. Christopher's Hospital is just the fun that we have operating. And we've got some pretty wonderful resources. We've got books, we've got good partners, and we've got ancillary folks to help.
Yeah.
And I think that's Snoopy, which is
That's
your
right.
little
That's
rescue. Snoopy's clearly expert on cranial and spine problems as she's eyeing the sawbone. I suspect she wants to gnaw at it. But we use all those resources because actually you'll remember there was one kiddo, an 8-year-old, that was really apprehensive about what we had to do to her awake.
Yeah.
And Snoopy was her, I don't know, her comfort animal, her pediatric benzodiazepine. She just got her to chill out and focus on the dog, and we were able to do what we had to do. But it's a real treat to operate at St. Christopher's Hospital. I think I'm not going to focus on too much because I'd like to get to seizures, because I think that pediatric seizures are really important to talk about. But here's a slide that shows a case that I thought, well, you brought to my attention. And we sort of polled some people throughout the United States and tried to figure out that this slide will show you, and it may not be inherently obvious to everyone, but this was a 13-year-old black belt, right? And somehow he...
real ninja.
Yeah, and somehow he fell and he became quadriplegic, didn't he?
So he was doing his karate kicks, and he had a transient episode where he lost the function of his arms and legs.
Yeah. And who would have thought that?
Yeah.
But that prompted some imaging, and we've got different images here. We have on the left a preoperative MRI scan, which shows that there's a problem at what's called the skull base, isn't there, Tina?
Yes, pretty tight there.
Yeah, and not only that, then the CT scan showed us something even more interesting, and he had a congenital problem called Klippel-Feil.
Yeah.
That's where the bones don't dissociate from each other in a normal manner. And this was a problem that was going to really, it wasn't going to abate. He needed something, and he needed something before he got hurt. And you can see, I've sort of mocked up on that picture, there's this thing called C2, and it's got this bullet-shaped peg, and that is actually pushing into the brainstem, and that was only going to get worse. And that would have been a devastating injury. So I remember the day we were in the operating room, there was a lot of angst.
There was. But you had actually obtained something that was really, really helpful. Can you tell us a little bit about what you got the industry people to do?
It was courage. No, what we did was...
Really,
Exactly.
this anatomy was very challenging.
The anatomy was challenging. In particular, the vascular structures were very challenging. And we created a model, because what I do when I do DBS is I get a lot of models in understanding anatomy. And we had a model that was real to life and basically did the surgery before we ever did the surgery. And it was still, it was still challenging. But I think both you and I will say that we're pretty darn excited about that last picture on the right, which shows a nearly near normal anatomy, wouldn't you say?
I can't believe how good it looks, and I have to say that having that 3D printed model before going into the operating room and being able to see, hey, can we really do this? Lessened our anxiety, because I probably would still be there if it wasn't for this one, putting in one of the screws, because this space was so darn small.
Yeah.
And there's really vital things going through those parts of the spine the outcome can be very bad if we put our screw in the wrong place.
Well, speaking of screws, I think that these are a different type of screw, and I think you'll remember this. So now we're really getting on to epilepsy. And epilepsy is something that I sort of take a soapbox with, because in the adult population, people will go for as much as 18 years before they get evaluated by a what we call tertiary or quaternary epilepsy center. And if you think about that, that's almost like you have a flat tire. Mm-hmm. You walk away from your car and you come back in 2 decades and you say, hey, let's fix this. And I think that is a real sort of challenge, epidemiological challenge and a societal challenge, Because you take people that would otherwise be functional and you give them a brain problem that goes on for 2 decades, which means that precludes their ability to work, go to school, have jobs, drive, or be functional. And so I'm a real stalwart about moving aggressively forward with identifying what happens in epilepsy. And we've actually uncovered people at St. Christopher's Hospital that we feel that we've been able to very positively impact, wouldn't you say?
Yeah. And that's why Atom puts crayons on the brain there. Can you tell us what's that?
Well, that just shows that I've got better PowerPoint skills than you do. But fundamentally, what we did was those screws are put into the head, and this kiddo was 11, and so he didn't need your dog. And he was actually really fascinated. He was just so geeky about this. He kind of reminds me of me. And just wanted to know, he just wanted screws in his head, and he wanted those electrodes, and he wanted us to listen to his brain. Because we had to figure out where his seizures were coming from. And nobody had been able to do that yet. And so those electrodes effectively are in the brain, and they're highlighting different places. The next slide is an MRI scan, and this MRI scan gives us just phenomenal anatomic resolution. There are some funny names here, the hippocampus, the neocortex, and the insula, but all of those places are literally just millimeters apart from each other, but it makes a difference as to where we can localize seizures. And if we can localize and point to one spot, then we can usually stop it, take it out, or use some other kind of really cool brain-machine interfaces. And you may recall in Azariah, we were really lucky, and this was an example of a seizure. We were really lucky to find out that this seizure, and that's what you're seeing in purple in that sort of top on the side, the very, very squiggly lines, we're able to localize where those seizures were coming from. That was the good news. The bad news was that he had an anatomic structure of language that would have probably put him at risk if we would have done this surgery. So believe me, I'm a surgeon, you're a surgeon, and we love to operate, but we don't like to hurt people. We want to help folks. And so we knew enough from this that we had to come up with an even more clever solution, so to speak. You remember that?
And can you tell, can you just explain how you figured out that the language might be affected?
Well, we were lucky enough that our group at Global Neuroscience, we've got dual-trained vascular surgeons, and we were able to do a study called a WADA study. And I think we're really blessed with the fact that we have 4 people that can do that, and so they've been able to help us in these kind of cases. And what we did here was we realized that if language was at risk, and you can see in this other picture, there was yet another spot that was also causing seizures that couldn't be removed. We came up with a really, really, really interesting way of mounting a brain pacemaker. That's an intraoperative picture of a brain-machine interface with artificial intelligence into which there's a microprocessor that those wires feed into, and they're constantly monitoring the brain. And when they learn the brain seizures, you'll see, this is real live EEG with somebody walking, talking. I mean, this is incredible. This is like science fiction, and this is what I love about functional neurosurgery. And you may not know it, but Azariah has not had any seizures since his operation, whereas before he did. And finally, that's what he looks like with that mock-up. He's got a battery in his head, he's got a microprocessor in his head, all in the skull, and then he's got these electrodes that are stopping him from having those seizures.
So from the outside, you can't see that
see
there's
anything.
any of these devices.
No.
It's not like he has to wear a hat.
No. He can choose to. I think he wears a slacker hat, but he doesn't have to. I don't know if you remember this case. Do you? This is here are some pictures that will remind you of our stroll down Epilepsy Lane.
Oh, how could I forget?
This was I think Caleb was 13.
Yeah.
And he had seizures. Mm-hmm. And somehow we couldn't understand why there wasn't a deeper investigation into where his seizures were coming from.
There was also a something very abnormal in his MRI to
That was
begin
the
with.
thing, exactly. And for whatever reason, our colleagues were just content because everyone's anxious with kids.
Yeah.
Should we do an operation? Should we not do an operation? It's always easier to use medications. But of course, you and I said, well, whoa, what is that? And there was that something that's kind of highlighted in yellow. And that was more likely than not to be a tumor, remember? And that tumor, unfortunately, is awfully close to a very critical area in his brain that was responsible for sensation. And so this was a little bit of a hybrid operation. This was both taking tumor surgery and epilepsy surgery and combining them into one. Again, the middle scan shows that we've got some electrodes in the brain. And what we did, I can't recall if you were there when we did this, but we actually, not only did we record where the seizures were coming from, but later we stimulated the patient and found out that we had a very, very precarious window of literally a no-fly zone where if we went any further, we would cause some degree of irreparable damage. And that was really critical for our navigation on that case. And you can see in the last picture, there's a hole in the head, which is, okay, maybe not something that everyone wishes for, but if the hole in the head takes out your seizure and it takes out your tumor and it leaves you seizure-free, I think that that was a real victory for us that day.
Certainly. And he's
seizure-free.
Seizure-free?
Yeah, exactly.
And the tumor's out.
And
So
the tumor's
it's,
out, exactly.
2 for 1?
Yeah, absolutely.
2 for 1.
Yeah.
Can you stop seizure medicine after these surgeries?
So I always tell people that while that may be a goal and that may be something that they strive for, we leave that up to the epileptologist. And typically they will keep patients on their antiepileptics for up to 2 years. And then slowly they'll start to wean them down because there's no joy in saying, we've taken away your seizure meds and then a seizure comes back. And so we like to be very, very cautious here. The goal is not to be medication-free, the goal is to be seizure-free. And sometimes that goal comes with both medication and surgery.
And usually, or pretty much always, those patients who are controlled with medication, they never come to us.
Yeah, that's
They,
true.
you know,
That's
we don't
true.
operate. If the medications work, great. But if you are taking medications and you're still having seizures, that's not good for the brain.
No, not at all. And I think that we, both you and I always say we're defenders of the brain, and we don't want anyone to have any seizures, whether they're aware of them or not, because that is not good for brain physiology. And so that's why I think we're both real strong advocates for being very aggressive up front at identifying where the problem is, not necessarily then saying you have to have a surgery, but we want to identify the focality of the problem. Yeah. This is something that we're doing in real time, and this is actually a case that I think shows the highlights of how having a multidisciplinary team with our neurologists and with ourselves, amongst ourselves, chatting, really, really helps in getting great outcomes. This looks like we've turned somebody's head into a pincushion. Those are electrodes, and those electrodes are arrayed throughout the brain. Before we got to our, I think this is an 8-year-old, isn't it?
Yeah, this is actually where one of the recommendations was to take out the whole side of the brain.
One half of the head, and we said, well, hold on, who's going to do that? And because we know how to do that, but we're only going to do that if we have to. And so they didn't even understand, or there was not an understanding of whether seizures were coming from the right brain or the left brain, and all those electrodes were helping us try to identify that. Ultimately, we were able to find out, this was just a couple weeks ago, that all the seizures were coming from those highlighted areas. They were all in the left brain. One was in that back area called the parietal lobe in pink, and 2 were in areas in the orange and the blue that were in more critical areas. So we had an idea that we were going to do both an open surgery to resect, and then ultimately, I think in a couple of weeks, we're going to use another brain pacemaker again.
That pink area is now gone, and that's that funny island that Atom made there.
Yeah.
And the neat trick was to follow that catheter through all the way to the bottom and just take that surrounding brain out to be really, really accurate, only to touch the brain that was seizing.
We've only got about 10 seconds. I'm just going to show a picture of our karate kid. And then the other kiddo is the one, is Azariah, who's got the brain pacemaker in. And I think we're just happy that we can offer amazing therapies to our patients. Thank you.
Thank you.
Okay, we do have some time.